Sinclair?
No.
Okay, how about Madeline?
Madeline's here.
Okay, so rather than me kind of trying to not be able to see people, I'm wondering if she would be willing to chair today's meeting so that it's a little easier in person than on the phone. So Madeline, would you be so kind just to lead this? Okay, great. So welcome everybody. Let me just say I'm in sunny Minneapolis on my way home from the National Healthcare for the Homeless Conference, which was a great conference, but I'm sorry I'm not there. And with that, I would ask Madeline to lead us for the next couple of hours, if she would. And I will be on mute until I have something to say, which I'm sure I will.
So I will go ahead and call the meeting to order, and I have to say that I think I left my reading glasses out in the car. So I will try to follow along and not run out to be able to get those. So
Do you want to use mine, Madeline?
Would you be okay? Thank you so much. So much. It's great. You can share right?
We're really a family, you know. I know.
Yeah. So we'll go ahead and do introduction, and we'll go around the room. And can everyone on the phone hear me okay?
Yes.
Now we.
I'm Wes Lucky. I'm Deputy Director for the Greater Columbia.
Ruben Peralta, Community and Tribal Engagement Specialist for Greater Columbia.
Sam Mordell, Director of Transformation in Greater Columbia.
Lori Brown, I'm representing social services on the board, but I'm from Southeast Washington Aging and Long-Term Care Council of Government.
Caitlin Safford with the Mayor Group, and I'm representing the MCOs.
Ashley Fernandez, Greater Columbia ACH.
Ruben Alvarado with Pasco City Council, and I'm representing local government.
Darlene Darnell, I'm with Catholic Charities and representing faith-based and children's food care program.
Lauren Johnson, I'm with Greater Columbia.
Ed Thornburg with Comprehensive Health Care, representing behavioral health.
Megan DeVos with Public Health.
Les Stone from Educational Service District 123. You didn't say where you're from, but I jumped in. Education.
Carol Moser, Executive Director of Greater Columbia.
Martha Landman, Columbia County and Garfield County Public Health.
Sandra Suarez, Yakima Valley Farm Workers, Senior Manager of Planning and Development, and I'm representing XYC.
Jorge Rivera Molina, Healthcare. You're not on the board.
Diana Halos, Greater Columbia Community and ACH. Kylie Spence, Director of Finance and Strategy for Greater Columbia ACH.
Ronnie Batchelor, Lutheran Community Services, representing the consumer. And Madeline Carlson, Board Secretary, and also representing transportation.
Pat Latay, Community Health Plan of Washington. Sarah Foster from Astoria Plains Hospital. Tanya Christie, Yakima Nation. Sarah Bullock, Dormant United Healthcare.
Welcome, thank you. And then as part of our agenda.
And then the phone?
On the phone.
Oh, I'm sorry, on the phone.
Rhonda Haas, Yakima Neighborhood Health Services, Chair of the ACH Board and representing the housing sector.
Samantha Frederick, Quality Behavioral Health in Clarkston and Garfield County.
Dan Ferguson, Allied Health Care of Excellence at Yakima Valley College, representing workforce.
Andrea Davis, Coordinated Care.
And just walking in.
Brian Gibbons.
Thank you. And you're representing.
What?
All right. So as part of our agenda, we have the attestation of conflict of interest and the self-dealing transactions prohibition and standards for approval. And I just ask that everyone review that. And then, public comments will be taken again, after the end of the agenda. So are there any public comments at this time? Okay, first up, we have the consent agenda or calendar, and we have the board meeting minutes on that. So do I have a motion to approve? Ronnie?
Second.
Sandra? Okay, it's been, motion and a second. All those in favor, signify by saying aye.
Aye.
All those,
Aye.
all those opposed, same sign. Motion carries. Thank you. Okay, we have the GCACH report and update.
Before we, can I actually add something to the agenda? There was a big provider meeting about the IMC incentive dollars. We can have an update on that and talk about the plan for maybe, I don't know, Ned, you want to talk about how the meeting went? And then if you guys have a plan or something so that we can fast track those dollars getting out of the ACH into the hands of providers, and we might need to vote on that next month so we can do a pre-discussion this month. That way it's not delayed even another month.
So,
I don't know if that's a financial.
I think that's a good idea to add it to the agenda.
okay, so, do we want that as part of the financial discussion as well, or as a separate item?
I think it could be a separate item.
Okay. We'll add it, right before Reuben's Community Health Fund discussion. Does that seem to fit okay?
Sure. Thank you.
Okay, so, reports and updates.
So the staff will share the GCACH report. We all contributed to the articles. And of course, the first article is around the current state assessment. So those of you who filled out a letter of interest and are interested in contracting in the 4 project areas with Greater Columbia are required to fill out the CSA, although you will be rewarded. And those are due back on the 31st. And we know that this is an arduous task. We know that there are many questions. We apologize, but most of this is for a requirement for our reporting to the Healthcare Authority, and the report is due at the end of July. And just to remind the board, 75% of our funding comes from reporting during this 2018 calendar year. So this is a really important element to our financial stability. So we're trying to push out these CSAs and get them back and trying to be flexible. The CSA is mostly around primary and behavioral health because this is primarily a primary care behavioral health initiative, although there have been community-based organizations that are filling them out and sending them in as well.
So I have a question.
Yes.
So in addition to reporting back to the HCA, is there really a kind of an understanding how the information that's gathered will be used for future projects or initiatives within the ACH?
Do you have a question about that, Darlene?
I just was wondering if that's been a thought, because I've definitely heard comments from people about the onerousness of the document. So I think it would be wise if we could give some additional information about, we're not just collecting this for the sake of collecting it, but about how it can be used at a later point.
Great. And so really the idea is to collect enough information for Sam and her practice navigators to go out and work with those contractors who are ready and willing to go into contracting in terms of the project areas and willing to do practice transformation within their organizations. We are going to try to commit to getting to all of the providers that are interested in contracting, but obviously we don't have capacity for everyone all at once. And so it's more likely going to be a staged approach, so that those providers that are ready right off the bat to do this, we can go into contracts right away. It might take some other providers a little bit longer. So the basis of the CSA will help us determine, and these will be scored by Oregon Health Sciences University, OHSU, our contractors, so that there's an independent assessor looking at the results of the CSA, and based on the criteria and the answers to the questions, they will help us determine the 15 to 20 providers that we will be contracting with the first year. Again, we're trying to roll this out as part of our strategy, knowing that we need to continue to move the numbers down the road. So we don't want to do everyone at once. Obviously, we don't have the capacity, but as we roll this out, then that will get us the numbers that we need to treat into the future.
Thank you. So I had a question. I just briefly looked through the, so you were saying that it's primarily for behavioral health and primary care. And if you really aren't interested in contracting with that, but you have Medicaid clients that have behavioral health issues, and you would like to have some coordination around that, should we still complete that piece?
Yes.
And then secondarily, if a entity doesn't want to do, I saw there was like care transitions, et cetera. So if they were interested in the care transitions piece, but maybe not the others, is that what they should?
Yeah.
Okay.
Actually,
That's the only thing.
Actually, it would help if you could complete the entire survey for areas that you're currently doing work with.
Okay.
Going forward, you may do projects in certain areas across the project areas, but we would, survey serves a few different functions. It serves to populate the major report, which is due on July 31st. It's part of the ready and willingness assessment, but also with the capacity assessment and analysis to help us understand the lay of the landscape, both at the individual organizational level and the system level. So if you're doing things in certain areas, but even if you don't have an intention of contracting with us, if you have the capabilities to filling out those additional sections, I think it's going to help us.
Okay.
And again, we know we keep on apologizing for the length of this survey. Believe me, it was a lot longer when we first started. We went through a lot of painstaking rounds to shorten it compared to CPAA, which is now close to 190 questions, and Southwest, which has about 165 questions. Ours is at 110 questions. So we really tried to strip this thing down as fair as we could, but still meet the needs that we talked about.
And I did not allow Wes to add any of the questions that were on the LOI. So, so we already have those answers. We can't ask them again.
Right. We try not
So,
to be
Carol?
Yes.
So it's Rhonda. So just in perspective, let me say I have completed ours, and it took us about 3 hours top to bottom, and that includes separating the data from the site and going through it. So just, for perspective, going through the whole thing, collecting the information on the numbers, and then answering the questions, the narratives, as well as the checklist. It was about 3 hours total.
And you get the gold star for being the first behavioral health organization, primary care organization to fill it in, F2HC. Thank you, Rhonda.
I'm expecting a whole lot more than a gold star.
Reward.
It is forthcoming. Talk to the Budget and Funds folks meeting.
Okay.
And so on these, and I was only able to kind of look through it and saw it really as an opportunity for providers, but in representing transportation or nonprofits that are providing supportive connection for healthcare. What do you see their role in this process as?
And let Sam answer that question.
Well, again, on like some of the criteria that we were looking at, that we really want to look at organizations as a whole to be able to support those practices and carrying out alignment for primary care and behavioral health, and also for supporting documentation and projects that, it really is based on that and capacity that we can be able to implement in care coordination and transition of care. We are looking at those entities as well.
But not through this process.
Yes, we are.
Oh, through
Kylie, you want to make the financial executive report?
Yeah, I'm sure majority of you have heard from either myself or Diane, who's been spam calling many of you. So this is just kind of an update of where we're at with the portal. We did release funding on May 4th to 29 organizations. That amounted to $86,000. We released another set of funding that actually paid out today/tomorrow, however the bank accounts work for those providers. So unfortunately, the portal is going down for a month. It's the 15th or the 18th through June 15th, which makes the next payment available on June 29th. So the portal is still open to register. So if you have yet to register, please do so. If you need assistance, there is a link down at the bottom of this that takes you step by step on how to register. You can contact myself or Diane. There's also in the bullets, there's the website and kind of just step-by-step instructions on how to register through that. And it does need to be the individual that was listed on the LOI. If you need that individual changed, then you can contact us, and we're kind of a middleman for that to PCG. So we can do that. And I just want to note, it's not the quickest turnaround. PCG is very slow manned, and so it has been taking them, I would say, 1 to 2 weeks to get things done, maybe longer.
And do you want to review what those payments have been for?
Yeah, the payments, we had $1,000 for the LOI submission, $1,000 if you registered within the portal, $1,000 if you are a board member, and $5,000 if you were a project facilitator.
Thank you. Any questions? The third item is just a little bit that we've been connecting with our congressional delegation. We got to meet with Congressman Dan Newhouse over at Tri-Cities Community Health. I was privileged to be able to be involved in that. I have to say that was the most amount of face time I've ever had with a congressman. We had an hour and a half with him. He was primarily interested in the dental services, the access to health services. We talked a lot about the opioid crisis, and then we went over and toured the Ochoa Middle School clinic. That was very exciting because Tri-Cities Community Health is trying to grow more services out of that community clinic. So it was a great informational meeting. And then we also got to meet with Raquel Crowley, who is a staffer for Senator Murray. And we, again, talked about our community partnerships, how we can strengthen those, and a little bit about some funding that's coming down the pipe for opioids. Sam, you can talk about Lourdes.
So Lourdes Healthcare has actually been working on integration and behavioral health and primary care, and they have hired their licensed counselors, so they will be fully integrated as May 18th, actually in June. Well, they've hired them, but I think he is actually going into practice on June 11th. So yeah, we're excited about that, and they're doing transitional care. They are working on their empanelment. They're working on their risk stratification. They have already implemented a common plan of care for behavioral health. And so, yeah, they're doing really well for 6 months and it's success. And their original target date was June 1st, so they're right on cue.
Right.
Yeah.
And talk a little bit about the EHR and the things you've been doing with their EHR.
Their EHR system, they're still having some issues with that. They've actually hired a consultant to come in and be able to build some templates. They're some success. I wouldn't say that it's been easy going for them, so it's been a real long process as far as being able to risk stratify, but they're using pre-manage to be able to achieve that. So there is some alternatives on that, but they really need the funding for the IT infrastructure.
What two systems are they trying to link?
They have Meditech, and they have the Allscripts, I think it is, for their other one, but they're using their Meditech to actually be able to integrate their care plan.
Ruben, you want to talk about advancing precision medicine?
Precision medicine, this is This health fair that was put together by Tri-Cities Community Health in downtown Pasco, right after the Cinco de Mayo celebration. The Cinco de Mayo celebration started on Thursday and it ended on Sunday with this health fair. And Precision Medicine is it's a group of all of us. It's called All of Us Foundation, and they're just collecting information from communities throughout the United States, and only a few communities were selected, and Pasco was one of them. And it's pretty much to zero in until a lot of the social determinants that we talk about ourselves here too, that we're going to address. And I took a couple pictures. People attended the health fair and some of the entertainment. I would say throughout the day, about maybe around 1,000 people kind of went to, because a lot of the dignitaries, that the mayor was there, the school district had representation. Raquel Crowley was there, also she spoke. Some researchers, they called in. They had a screen there. They had a big screen. You can probably see it there. So Jim Davis from Tri-Cities Community Health also spoke. So it was a pretty good event.
And weren't the NCOs there also?
Yes, that's right. I'm sorry. They were all there. Molina was there. Just about everybody.
Thank you. So thank you to those that are on the practice transformation group. We gave them a little bit of homework in trying to determine in the CSA, what they felt is really important in terms of change concepts. We had them score the list that you see in your packet: equity, value-driven, adaptive, collaboration, transparency, leadership, and volume. So during the meeting, we talked about what each one of these meant. They came with specific definitions so that they could understand some of these change concepts. And then we sent out, and I guess this is actually in our packet that we'll be talking about later, but you can see the results, that leadership and collaboration kind of came out on top. But it was noted, as we talked about at our last meeting, it was noted that there wasn't a huge difference between all of the different selections. So it was pretty evenly spaced, but I think that this is one of the things that we will be looking for. I shouldn't be tipping my hand here when you're filling out your CSAs.
Cheryl, can you talk about what was unexpected when you looked at the results?
Yeah, so unexpected was that volume was scored really high in some places and really low in others. So that was kind of a surprise, is that volume didn't have as much weight with some individuals as others. And maybe it was due to the size of the Medicaid populations within their organizations. Hi, how are you, Jim? Were there any other surprises that I'm forgetting to mention?
Oh, that's the one.
Yeah. Any questions about the homework? How about the DMHE update?
So the DMHE committee, the data management and HIE committee met. Jorge is the committee chair, and we work together to oversee that. We're looking at a data flow model, which is primarily focused on key paper performance right now. However, the committee will probably be expanding its work to think about a flow model for paper reporting, which may be a portal or survey or some other mechanism. We're also talking about data sharing agreements. I think there's belief that the committee needs to expand its role, to cover some additional work, and also expand who's on the committee so we get appropriate representation, including clinicians who need to feed into this process. So we have a meeting coming up, I think, in a week or two.
Next week.
And anything you want to add to that, Jorge?
We need providers. As I said, we are meeting. We need IT people from providers to join this group so we can have more technical conversations on how the records should look like and how the flow of data should look. So far, we only have one organization participating in those meetings, the Seek Now Health. But we need more primary care direct delivery organizations to join.
So to add to the data conversation, I wanted to let people know that we went through an RFA process to choose an IT care coordinator that's going to be overseeing a pilot project that we're doing. We sent out the application to a few organizations and chose GCACH County to engage in the care coordination pilot. And this is part of our obligation to do something around care coordination. It's also an experiment to see what works and what might not work. We may expand the role of the IT care coordinator. His name is Rob Arnold. He works with Plotting Partners. Or we may be hiring another consultant to help with IT. I think the organization needs more technical expertise than certainly I can provide. I mean, I think we have the ideas, but someone needs technical horsepower to say this is how we do it. So more to come about that.
Who do you want people to contact if we have an interested person from our IT department who could be helpful? Who do you think?
You can contact me or Jorge, but you can contact me at.
Because we have, right now we're going through implementation of a new health record. So we're going through the state reporting build. So we're doing a lot of this stuff right now. We might as well share it because we're going to learn some lessons the hard way, I'm sure. Hopefully a lot of them the easy way. But we know there'll be a few hard ones, so we might as well be sharing it.
And that's exactly what we need, people with IT scars.
Okay. We've got them.
That's funny, but it really is true. You learn more, I think, from your mistakes than what works well.
So Wes, do they have to be from one of the organizations, or can they be outside the organization? I know someone from classes, really like master in IT. He works right now in infrastructure of that.
There might be a role from that consulting standpoint that I talked about. If you want to connect, as far as the committee work, I think we want to focus on the organizations that are going to be part of practice transformation. And, Sam talked about how we do this build-up from within the committee, within the organization around population health management. It's a term we've talked about. We had a whole leadership council devoted to it, and that is part of the core work that has to happen around risk stratification, empanelment, patient registries, data analytics, quality reporting. Those are the aspects and more of a 21st century healthcare organization. So I think our primary aim, or one of our primary aims, is to facilitate that. And then with that, see how we can connect organizations together so they can share care plans, do referrals, and more. The state has got a lot of work going on through One Health Board, as many of you know, and the clinical data repository. We don't want to interrupt that, and we support that work. But at the same time, we have to get our work done so we can get paid.
Could you, you said GCACH County was chosen for a pilot for care coordination. Is that pathway?
No.
Okay.
No. Okay. The organization chose not to go with Project 2B, which was around Pathways Community Hub, and we haven't backtracked from that.
Any other questions for Wes? Ruben attended an ACEs conference. Did you want to talk about that at all?
Yeah, it was a first childhood experiences workshop in Yakima, and it was / trauma informed care. And I'm pretty sure most of you know what ACEs are, but just really quick, these are experiences of your childhood that pretty much traumatized you. Any type of abuse, divorce of your parents. Those if you have a high ACEs score, you are multiple times more likely to smoke, to abuse alcohol, to become parent as a teenager, and many of these conditions. And these are people that were not able to cope with those experiences. Many people do cope, but many those who don't have the mechanisms, their resilience to cope with them, they carry that throughout their lives, and it turns out into an actual physical illnesses. So and school districts throughout the state are also looking into trauma-informed teaching as well. So ACEs is becoming a big thing throughout healthcare and education. So this presents a tremendous opportunity for us as we go about devising our process, our systems to address the social determinants of health. For us to do it through an ACES lens, perhaps. So that can address many things in helping families, helping people develop that resilience so they can overcome ACES. And it's estimated that $168 billion is lost in productivity every year in the United States, because many people can reach professional level jobs with degrees. However, they're still dragging some of those experiences that they don't know it's affecting their productivity. But a lot of people miss work, as a result of the effects of ACES. Even people, when they show up to work, many times these experiences affect their productivity while it's
add a little bit to that conversation. Go ahead.
Yeah, this is Dan Ferguson, and the Allied Health Center of Excellence actually hosted that training. And the most interesting thing about that was the initial target audience was health workforce faculty from the community college system, and the secondary audience was clinic managers. And we actually had about a 70-30 split, primarily from industry. And so we need to do a lot more work with inviting and informing the importance of our health workforce faculty on the importance of ACES and trauma-informed practice and health workforce training. The incumbent managers are all about that. I mean, they recognize the need, but there's still a lot of need for educators to kind of recognize the importance of this. So appreciate you attending the event and spreading the good word about that.
And just a little bit about the ACES discussion. We talked about trying to bring in a national presenter to talk about ACES. We originally thought of Dr. Anda, who was one of the two initial researchers.
Coming to Walla Walla in just a couple of weeks. There's a Beyond Paper Tigers conference that's hosted in Pasco this year. Oh, okay. As I say, they bring in speakers for that.
So there's a real popular speaker who was on the TED Talk, and I think her name is
the provider, the pediatrician.
Yes, African American woman, something Harris.
I think it was Jennifer.
Cool, thanks.
In any case, we're trying to reach out to her for her to come in to speak in some of our areas. We originally thought about bringing in educators, although we've heard from some people who are involved with this intimately that educators seem to be pretty well educated on this. But primary care providers for sure would benefit from hearing about this. So this is something that we've been talking about, and Ruben will update this when this happens.
And yesterday we had a ACES, like an informal class from Ron Griffin over at Jubilee, and we had about 30 community members come there. So we're seeing great interest also just from the community to learn more about this, and just those concepts and those terms are sticking with people.
I always worry that it won't go. I mean, we know the adverse childhood events there. We know they impact people. But I always worry the conversation stops when people have a good understanding of what they are, instead of talking about the natural primary supports and the resiliency and celebrating resiliency on the other side. Sure. Because it's easier to kind of finally get to a place where, I understand why this happened, and we forget to move on to what are we going to do about it.
I can really concur with that. I mean, because I feel like there's been lots and lots of educational things about ACES over the last 5 years, but there hasn't been a lot about, so what do you do next? So I would very much concur with that.
Ron from our Jubilee Youth Ranch, he comes in and he does staff trainings. He came in and did training for our staff and all county employees, but about the implementation phase of that, what to do with this information, and just even how to treat one another, that internal customer service, not just external customer service. And that's local. I mean, Rick Griffin. It's like, I know I'm not, name's not Ron. Rick Griffin, I mean, he's amazing. It's relatively inexpensive too, but we have a lot of local resources. I mean,
could you forward those names to Ruben, and we'll start to collect them and see who we can bring in, who's best suited, frankly, who we can afford, and then go from there to try to arrange an event, start the conversation. How we address it after that, we'll have to deal with once we get to that point.
I just want to echo what Ed and Megan said. I know I've been in a conversation recently where some of the educators who are more educated are actually starting to feel fatigued over the education and the lack of action. And so I think that would be really beneficial that we kind of take it to the next
Rhonda.
step.
Go ahead, Rhonda.
So I just wanted to add, I really echo a couple of comments I just made, but I also want to say that, you know, this is one of the areas where I think the healthcare for the homeless providers have really been at the forefront of a lot of this. And again, a lot of this we were talking about at this training I was at, but a lot of the resiliency training and how to act up on the information that you know. And I will also offer some suggestions to Ruben on some trainers, because I think with the primary care providers and the social workers and the case managers that have been dealing with a lot of the folks that we work with in the homeless community, that there's a lot to offer from that perspective as well.
And I wanted to also share Benton Franklin Health District, United Way of Benton Franklin counties, and Greater Columbia 211 have been working around ACEs and creating kind of a bullseye of different sector resources.
That's Robin Henley over at the Benton Franklin Health District. And there's a group of people that work specifically with ACEs. And they're the ones that brought the paper tiger forward for the showing, the first one. The person that you guys were talking about was maybe Bert Harris.
Okay.
So she has a real good repertoire when she does the TED Talk. I suggest you guys watch it. It's really interesting to listen to her.
So Ruben and I got to go to the Whitman County Health Network meeting a few weeks ago and got introduced to one of the educators that is doing, it's kind of the next step beyond ACEs in their classrooms, and it's called CLEAR, and I can't remember what CLEAR stands for, but it is a program of work that's around trauma-informed practices. But what they do is in the classroom, they teach the kids when they come into the class, they try to get a pulse on how are those kids feeling, and they base their education on the hand, which is similar to the size, well, I guess that my brain, I hope, is a little bit bigger than my hand, but they use the hand as the example, and that if a child is feeling really wigged out, I mean, that they use hand signals, and so the teacher can say, so how are you all doing? And then get a pulse of, are those kids ready to learn? And if they're not ready to learn, then they have a place where they can go in the classroom so they can settle down, because, and Les knows this, is that, you know, kids have to be ready and willing to learn, and they need that environment, and sometimes they just need to get settled in. So they're applying it in really innovative ways, but I see that as one of those next steps that we can be taking with this training, is that implement it in the classroom, and then the kids take it home to their parents, you know, and say, hey, you know, I'm kind of wigged out today, and isn't that the way we started reduce and reuse recycling? We started with our children, and so having those kinds of programs in the school, I think, are really effective. So more to come.
I want to touch on ACEs again when I go over the community health.
Okay. All right. Did you want to talk about Janet?
Jenna Rogers Sheldon is coming to Greater Columbia on Monday, and she is our Texas navigator. She's coming from Yakima Valley Farm Workers.
Sorry.
I'm going to come up in contract negotiations, don't you worry. No, Jenna's amazing. So. Yes, and she's very passionate about practice transformation, and she received her degree at the University of Georgia. She has her master's, and so we're excited to have her starting Monday. Yeah.
Jenna's great. I've met Jenna too a couple times.
Yeah. No, Jenna really is amazing. She was in one of our first class of our formalized administrative fellowship program, and she was amazing, a superstar standout of that group, for sure. So she will do wonders with this group. You guys will all love her.
Georgia,
That's
the bulldog. Right, the bulldog. Not really.
all right. So under the financials, Kylie, if you'll take us through those.
So the first on the list is the balance sheet. You'll see in our checkings we got the $38,000 and our money market the $5,700,000. $14,000. Everything else is pretty normal. We did get a $500 refund from the Northwest Rural Conference because we overpaid. But other than that, today we have the $5,753,831. The next form is the budget versus actual. So you'll see the revenue sources up top. Something new on there is the American funding for $20,000 that was given to us to essentially do something with the community health fund, which we've had discussions around it as staff, but we haven't finalized what exactly we're going to be doing with that. So we have the total revenue of $6,185,000. To date, we have $20,615 in investments that we have earned from interest on money market. And we're still working off the design funding. We just actually pulled down the district funding. So some of the concern, the burn rate on the payroll at 76%. There's one more payroll hitting that, and then we will be moving our funding to the district. So we won't be concerned of overspending in that category. You can see the contracts is the next highest at $111,000. And that's due to, we did make 2 LIN payments, which you'll see in the statement of activity. Facilities, $24,000. Operational expenses is a little higher too, because we didn't quite budget for all the offices and all the office equipment that we would be needing for all of our new hires, and that's the pace that we've been growing. The travel, $7,000, and miscellaneous service costs is $6,000. So see there. The AmeriGroup funding has yet to be touched, and we haven't spent anything new in the Yakima Valley Foundation funding or the HRSA. So to date, we have spent a total of $384,000 out of the $1,926,000, which is 20% burn rate. We're being pretty conservative, but once contracts start kicking in, I'm sure that funding will go up quick. And then the next two on the list is the statement of activity. You have the rolled up version, and then following that in the larger printout is the detailed version for if anyone wants to know exactly in which category what was spent. Some of the outstanding or abnormal expenses that you'll see is the $60,000 LIN payment. We did get the deliverables from GCACH LIN and Whitman LIN, so we made the $30,000 each payment to both of those. Regular payroll expenses, and then there is another expense under 2C contracting service for $13,770. That large expense is for Oregon Health and Science University in tenfold for working with that contracting group. We've been using them a lot, especially for development of CSA and his assistance in a lot of the categories. Any questions on any of that?
Just a quick question. Do we have all of the local health improvements in place already, or are we still expecting more?
We have all 6 in place. We have the contract, so now we're just waiting for deliverables from 4 of them.
Okay. Thank you.
Okay, does anyone have any questions on that? And I will look for a motion to approve the financial.
I move to approve.
Second.
It's been moved and seconded. All those, any further discussion? All those in favor signify by saying aye. Aye.
Aye.
All those opposed, same sign. Motion carries. Thank you. Okay, Kylie, approval of the LOI cutoff date?
Yeah. So, I mean, as you all know, we've been accepting LOIs, and now that funding has started to disperse out and the CSA has been sent out and is expected in the next 2 weeks, it's been recommended from the Budget Fund and the Finance Committee that we cut off LOI acceptance immediately. That doesn't mean that, and that's just for the provider engagement funding. That doesn't include the community health fund. So there's still a lot of different pots of funding that other organizations that may have not submitted an LOI can get involved with.
So originally, when the LOIs went out in September, I think the cutoff was pretty close. The original cutoff was pretty close to that date. And the ACH showed a huge amount of flexibility, but we sort of need to close the curtain here, probably because of the CSA and probably because we need to begin the next process of readiness assessment, contracting, practice transformation. We need to go forward, and it's going to be difficult to have this LOI process continue to operate while we do this other work.
And we will open it up in 2019. But at this point in time, we've got our hands full, and there needs to be just a definite board action so that we can feel comfortable dispersing the funds and knowing exactly how much money we have to deal with for the rest of the year.
So I raised the question because there was the finance committee, there was a request for an electronic vote to send this forward as a seconded motion. And I guess I don't really care one way or the other, but I'm not sure why we have to give you or grant you permission to enforce the cutoff date that's already been published. I think it's a one step too much of Mother May I. You publish a date and you can close it.
We had a deadline, right?
Yep.
Have we passed the deadline?
Yep.
Problem.
Well, but there was a deadline actually on the LOI that was like months ago. And then there was also organizations that kept submitting after that. And so there were a number of organizations, and I don't know how many, but that submitted after the cutoff date. So,
I think it's okay to inform us, but I think you're well within the scope of what you've already done.
right.
To just publish something to that, if it's still even available electronically, publishing is saying this will no longer qualify an entity for engagement services. Because you've already done the work and you've already done the communication. I don't know that you needed our permission. But again, I'm willing to vote anyway.
So
Right.
this is Rhonda, and I agree with everything that's been said, but I guess I feel like because we did allow some after the deadlines, it just makes it more formal and clear that the board is aware that happened, and to have a motion that says we're officially saying that for 2018 we are closing it off is the more prudent way to go, and I don't see a downside to doing this. So that's why I'm in favor of this motion.
I think we're all on the same page.
Yeah.
So,
Let me just share with the board what I know about my meeting last week in the Southeastern Washington Health Coalition, because there was a provider there that noted that there was a school district in the very far end of the region that had submitted an email asking to be participants of this on May the 2nd, and that they received a letter saying that it's too late for them. I don't know much more than that, but I believe this being a school district, which is an important and integral part of this, somebody should at least reach out to them with a little more than a memo that says it's passed, because I also understand that the deadline had not been passed when that email came out. And I think it's in everybody's best interest, particularly when there have been exceptions made, to listen to whoever believes needs to be part of this, and there should be some direct engagement with them, saying what is it that you believe, because many times they're even confused. And one of the things that we know very well about how we've been working here for 4 years is that the level of engagement and knowledge that Yakima has of what's going on versus Ellensburg versus Pomeroy, for that matter, it's different. And getting for people to understand the process has different levels of challenge. So I would say if there was a communication from an organization before the deadline saying that they were interested, and we understand that this is an organization that would be important to have engaged, it would be the duty from the GCACH to connect directly with them, and maybe there's room for an exception, or there's a need for an exception.
Sandra, hang on. I think, Carol, did you want to respond to that?
Well, I think Darlene's right in that we have made exceptions primarily because when the board made the determination we weren't going to be doing network contracting, we had to reach back to all of the networks who then had to supply us with individual LOIs. Some networks had 5 or 6 organizations that were attached. And so we felt that it was important to include them in the process. So that required us to go out and get those LOIs. With regard to the Clarkston School District, they did contact us, and at the time, we had a budget and funds flow committee meeting. We had talked about the cutoff of the LOI, but we hadn't, I think, put it in writing. And so that was part of the process, is that we failed to put it in writing. And I think when you're talking about being transparent, you need to have written minutes and motions about these really important dates. So that was part of the confusion with Clarkston, is that we had remembered that we had the discussion, but we just failed to get it in the minutes. I appreciate Rhonda's response to this, because it's really important for me to be able to show our constituents that this is the formal motion that the board made, and so that we can move forward now to say this is an action of the board. I think it's May 8th is what is being recommended for the cutoff of the LOI, so that the staff can then just continue to do business.
And I'll respond from the Budget and Funds Flow Committee. So it came up to that committee, and we moved to move it forward to the board, but we didn't think that the Budget and Funds Flow Committee could make that determination solo. So that's why we asked for it to be moved for the board and then to be disseminated. Because there has been exceptions of people coming in after the original date of October, whatever that was.
So I don't want to completely disagree with Jorge's comments, because I do agree with the basis of them. I just don't fully agree with the fact that I know Carol and team, as they have all come on board, has put a tremendous amount of effort in reaching out to folks, and yet we still see a drop-off in our leadership council meetings. And some of that is because some organizations have made the decision they don't want to be involved, and they made that decision months ago. And we're not, with this motion, saying that they can't still become involved. If we were missing a huge sector that the staff felt like we still needed to do some outreach to, then we would make that exception. But I think for their sanity and for our ability as a group to be able to move things forward and hit our reporting requirements and timelines and targets, and make sure that it is representative of everyone who has put forth the effort to make sure that they read the emails that come out very consistently. I think we probably should go ahead and honor the staff with this motion so that we do have a cutoff. As Carol said, we'll open it back up for 2019. Hopefully after dust settles a little bit and we get over some of these big hurdles, we can do some more of that outreach, identify, we'll have a better sense of what's still missing, who else should we still have at the table, knowing where we're going. So, I mean, I honestly think if this is what will help the staff kind of get us to where we need to be, then I think we should do it. So with that, I motion that we do approve the LOI cutoff.
Nice second.
Okay, there's been a motion and a second. Further discussion?
Yeah, so I have a question about so I actually don't even know all of the different entities that have filled out an LOI. It would be helpful to be able to see that so that we can see the geographic spread and not that long ago.
I think it's the 155 entities represented in the funds distribution list, I believe. Is that correct?
Okay. I can go back and look at that, but I'm not understanding fully what the implementation structure is for the dollars. So how do we know if we actually have enough CBOs if we don't know how this is being implemented? I think in a lot of other regions, the way that this is being talked about is that there are providers that are grouping together, working on the project, and for some regions, they are going to try to require the actual providers that provide care, not necessarily social services, to contract with social service entities or CBOs to work with in the demonstration so that they are addressing social determinants. With the idea that from a sustainability standpoint, it's easier as MCOs to be able to contract with that provider to sustain that kind of work versus us paying and contracting with the CBO to become a Medicaid provider, because that's way more complex and administratively burdensome for a lot of CBOs. So I'm just not clear on what kind of actual implementation structure we want to do here that will help achieve the metrics. We may not have the right mix.
We can make the list of those that received the LOI available when the LOI first went out.
So this is Rhonda.
Hi, Rhonda.
Yeah. So I think Caitlin, if you there's the I would just say I think that was Caitlin, right? there's the list of the LOIs, but I think also we're going to look at the community fund that's also going to address, that's still going to remain open for other community-based organizations to be able to work with. So I think that there are two groups of people for the smaller organizations that did not complete an LOI that are still going to be eligible to participate. So don't forget that group as well. So I think that if you look, first of all, at the LOI group on the CBOs and the Budget and Funds Flow Committee, Darlene, you might want to speak to the fact that you guys reviewed that and how you felt and came to that decision.
I don't disagree with that. That's not really my question. My question is, what is the implementation structure for meeting the metrics we have to meet? Because even if there's still a process where we can recruit CBOs, we may not even know which CBOs need to be a part of this yet, because we have no idea what the structure for implementing this is actually going to be. Or is it up to like a Sunnyside on its own to figure that out? And if that's the case, then that's fine, but then we probably should have a discussion about how Sunnyside,
We're going to make that.
Build the wings on your way down, right?
Yeah. How they involve CBOs, or how we connect the CBOs that have submitted LOIs with Sunnyside to be able to meet the metrics that exist around homelessness. And I think there's only one, and that's only the bi-directional one.
You know, that was
I feel like
part of
those
the reason
questions are
why
asked in our CSA, sorry.
that's part of the reason why we set up the LINs to begin with, to help address some of these social determinant agencies, related agencies, to become involved at the local level, because with the wide geographic footprint that we have to try to do our outreach to everybody, even though we sent it out to 600 organizations, still may not have been enough. So this is one of our earliest ideas, and through that type of attachment, we're hoping that we'll get the appropriate providers involved. But I'm going to push back a little bit. At some point, individuals have to be accountable for the fact that they received messaging and they didn't respond to it. I'm going to be blunt about that.
No, it's clear, but it's also clear that some individuals didn't receive the same degree of communications than other individuals in different moments, because the network was developing. And to the point of the LIN, it is precisely at the LIN level that these concerns are coming. So it is at the LIN level that they are saying, can we still come in? And this is a LIN that was formed. I attended the first meeting of the Kittitas LIN, and that was more than a year ago. This one was just formed 2 months ago. So I believe there's room. I mean, if the process had been perfect and accurate, I would have no problem with the process just saying, oh, deadline's fast. But since the process has not been perfect or completely accurate, I think it's important to open to different situations that are different in the structure of Yakima than the structure in the Southeast. And I really want to speak a little against making this a battle between honoring the staff versus listening to the voice of a rural community, because that's the worst thing that could happen to the group as a whole. I'm not advocating for this. I'm not disrespecting the staff. I know they have a job to do, but at the same time, I could just said I have been to 32 counties of the 39 of the state. I know that things are different there. And if you want to hold people accountable in Pomeroy with the same criteria you hold people accountable in Seattle, well, okay, let's do that. But I think it is different. And if you look at the particular situation, and if you have somebody attending the LIN and talking to these people and saying, well, maybe there's a good case for this organization to be part. This is all framed in Caitlin's main point being, if the structure was clear, we would say, oh, we really need a school district in this region, because otherwise we're not going to be able to achieve this. Or we really need a primary care provider, because what if no primary care providers signed up from Pullman? We just say top block Pullman. So I think that should be considered.
Yeah, I have a really good example to give you from the Southeast Washington Health Network. We just realized at our last LHIN meeting that Jorge was at, that Chaz Health in Lewiston might be available to join, and because they serve a lot of Medicaid clients across the border. Because Chaz is based in Spokane, we might be able to bring them back into the fold. We're doing some research on it to see if we can bring them back into the fold. If we make this decision, then I don't have a provider in Asotin County that needs a lot of work that I can go to and say, can you, they serve the majority of the Medicaid clients. And I'm going to say, oh no, we can't move our numbers in our LHIN because we can't get a provider in Asotin County that has most of the numbers. It doesn't make sense to me. So if we could do it with exceptions considered or something like that, that would be appreciated.
So
Can I
I
ask
have
a clarifying?
two questions. Why May 8th? And then what would be the date that it would be, the LOI would be open? And would that, is the intention for that start January 2019 when you talk about they would be open
We're doing
in
it.
2019?
We haven't gotten to that point yet. So technically, the LOI has been open since September 5th through May 8th. And that's a long time to have an open process. And the staff did make a tremendous effort to reach all parts of the state. In our LOI list, we're really proud of, we have 55 Medicaid providers on our LOI list that represent over 155 clinics. So we did a lot of outreach to all parts of the state to try to get those providers to submit an LOI. And then we also have about 42 non-Medicaid providers, is that right, Darlene? About that many? But if you look at the LOI gap analysis, and I think it was that Kylie created the first one, we have great representation from across our region. And we have all the hospital systems except for trios. We have all the F2HCs, we have all the CHCs, we have independent providers, we've got social service agencies, transportation, public health, fire departments. I mean, we have a wonderful list that would be happy to share with you, Caitlin, because actually we're really happy with the number of providers that have come forward to be a part of this process. And I'm sorry that the process isn't more clear. I think we're still kind of building this plane as we're flying it, so I don't know that everybody has extreme clarity. We do know though that Sam will be working with those CSAs and those LOIs to form these natural communities of care.
Okay. So
because so that we can see, and even in the CSA, again, I'm tipping my hand, is that there are several questions that relate to what are your partnerships? Yeah. Who are you partnering with? Because we're going to be analyzing those to say, oh, okay, so here's this network that's already working together. How can we help them? So I think we're getting there. We wish we had more definition for you, Caitlin, but we are looking at this through the lens of practice transformation and communities of care.
Okay, that's helpful. I think that as a sector, we've been starting to get pretty concerned about some regions not having like a understandable implementation strategy, and then some regions are like way far ahead with that and have something that's set out for the next 7 years, which is that. So that's a vast difference. And as statewide entities, to not have that consistency starts to get really concerning. So we're just trying to understand where we are. Natural communities of care makes sense. We're used to that. That's in a couple of different regions. And I think you'll find we just start to ask questions, and especially with funds flow, like, great, and once we have those, then what does that mean for the next 5 years, and how can we plan it out appropriately so that the metrics are more, that's how we're getting money, metrics being met.
So I'm hearing that the May 8th date was already sent out as a closing.
No, that's what's on the table.
So actually, I would need to amend my motion because I did not include the May 8th. So I would need to amend that to include approval of cutting off the LOIs as of May 8th, effective May 8th.
And so I'm not sure that I heard why May 8th.
Because the CSA was sent out the 7th, and we want these to be coincident, so that we're not lagging in terms of, okay, here's somebody that just has submitted an LOI, but they can't submit their CSA because it takes a really long time to fill out. Yeah. And we can't extend that process because we have a deadline on July 31st, and we need the information from the LOI.
So what exactly happened with that school district? Because what I heard last week is that they sent the email on these on May 2nd.
They would be included, Jorge. With this motion of the board, we will send them an LOI to fill out.
So To clarify, all this really does is caps our financial exposure on engagement dollars and then stops
Yes.
the flow of new information. And
Yes.
it's that simple.
Yes.
And so again, this is an operational deal, and we've talked about wanting to honor the staff by voting yes. I think we're dishonoring the staff by not letting them run their business.
I do have a question. As far as I know, we work closely with you here as far as the Yakima Nation. We have many tribes in Washington. How many tribes have we actually sent that LOI to?
So we sent our LOI to the Yakimas, that all of the ACHs are working with their own tribal tribes in their areas.
Because I know that there's other tribes within our area besides us. Although we are the largest of the tribes, so we cover a lot of land. However, we have a lot of tribal clinics and behavioral health clinics that I'm wondering, did we reach that population?
So the LOI was set like to the mothership, the mother organization. So if it's a Providence, then it would be a Providence might have a couple of different systems across the state, but we would be dealing with the Providences in just our regional service area. So if you think that we're missing a tribe that's within our Greater Columbia ACH, then we would need to know that.
And I believe Healthcare Authority and Indian Health Services have reached out to the tribes to make them well aware of this process going way back last year. So the tribes are understanding of what ACH is covering their lands.
Okay, I just want to make sure because, most of our people tend, just because of reliability and placement and transportation and wanting to stay within their own community, they tend to go to our clinics. I mean, and we're understaffed anyways.
Yeah.
And so, that becomes, and I just wanted to make sure, so, because I'm here to report back to our council and to my manager. So I was just wanting to know that, because I know you guys do a great job. I, keep in contact with you guys all the time. So I don't have, but if I'm here representing, tribal entities, I feel like I needed to ask that question.
To the best of my knowledge, and I looked at this map because tribal relationships is my responsibility. You guys are the only tribal provider in the Greater Columbia region. There's other tribal providers that serve tribal people in Spokane, and that say in Greater Columbia there's only the Yakima Nation clinics, which is one of them, but it's, if I'm not mistaken, that it is. So they all have received that. So I guess if the question is, have we reached out to the Healing Lodge in Spokane, who sees people from all over the state that are tribal? I don't believe that's been done, but that would be beyond the initial scope for sure.
They're involved in BHC. Well,
They are on BHC.
Yeah, I just wanted to make sure, because I know with our tribe, I don't think we were, even though I've sent that LOI to our tribal council and, or man at the time, I don't think we've gotten it done, because we have to go through a whole process of getting it through our tribal attorneys, passing it through our whole tribal council, and then we have to switch over in November. I was still sending it to my program manager, where are we at on this? And I'm actually just texting her right now, waiting for a response, where were we at, So I know for us, we're probably gonna have to wait till next year to do anything, and, so having an actual ahead of time date, for me, would be helpful. I know that's a lot to ask, but it's a long process.
No, I think that's reasonable. Have clear opening and closing dates.
Can I just say one thing? Jesse Dean sent out an email. I'm not sure if you were copied on it.
No, I don't get them directly unless I contact him for something.
He sent out an email to the leadership requesting that on June 18th. And he was encouraging tribe to allow the ACH to attend also. And Kathy Solusi also.
That's my program manager.
Okay, so she was involved in planning of that meeting. So it's going to be Jesse Dean, Lena, and Vicky. So I don't remember Lena's last name.
Nation.
Yeah.
She used to hang out around here.
I can give you her name and email her.
Okay, I have it. I just didn't remember the last name.
I can follow up with Kathy on
So
that.
yeah, so maybe.
Well, that's the thing, it's after our Treaty Day celebration, because that's the week before. And
Yeah, that email went out last week, I think, and maybe they replied directly to Jesse.
Okay,
And
and I'll have you follow up with that. So we have a motion and a second. Is there further discussion, or do people feel comfortable in being able to? Oh, okay. All of those in favor, signify by saying aye.
Aye.
All those opposed?
Can I just clarify for the sake of the minute? So we're still going with motion by Sandra, seconded by Darlene, and then there's the discussion, and with an amendment just to include the date itself.
Yep.
Okay. Thank you.
I think that as soon as we can send out those, that engagement potential date for 2019 would be very valuable.
And if somebody expressed a desire after this, that they would be able to have some kind of a letter saying, thank you very much. Please remember that this is when you're going to be, so we keep them somewhat on the hook, so they will feel like, you guys do that already. So.
All right, thank you. And then Caitlin, were you going to lead the discussion on the behavioral health meeting?
Happy to start it. Sure.
Okay.
So on last Thursday, yes, I'm looking at my BA department. The BHO providers met on their own to talk about the IMC incentive dollars and what they need to use it for their own capacity building for integrated managed care. So right now we have 7 months until we go live with IMC in this region, and it's a lot of work and it takes a lot of capacity for the BHO providers making the transition. So I know you guys met and I don't know what you guys talked about, but I do want to make sure that this board isn't a barrier to those funds getting out to the providers as fast as possible. And because we have processes that we need to follow with funds allocation, I thought at least we can have a discussion about it today. Then next month, since our meeting in July is not happening, next month we can approve the IMC funds so that they can go out in the June 29th, the June 29th funds. What is that? Funds release, sure. So I just wanted to bring it up, and maybe you guys could talk a little bit about what you would need it for, but I don't know exactly how the board wants to approach this. I just know that we do not want to be seen as a barrier to this right now. Super political issue, and it's as soon as we can get the money out, the better.
Sure. Do you want to start? Want to go?
Okay. So I called Carol after I think Friday morning and spoke. So and have you received anything from Danica or from Mike?
Danica communicated that Mike was in the process of writing a letter.
Of drafting it, okay. So the group had met and they offered a number of different discussion points and models for looking at how to get the funding out. To kind of set the tone for the meeting, Healthcare Authority had provided a 2-page document going into the meeting that identified about 13 different elements of consideration that organizations needed to be concerned about as they were moving forward. And so the initial proposal was to pass through the funding to all of the contracted provider agencies in a manner that was consistent with the current funding formula used by the BHO. After some additional discussion, there was an idea that it might be wise to have a contingency withhold so that if they found emerging threats that happened in that 7 months, there would be a contingency fund to be able to deal with those. For example, if one organization's self-assessment found that they were in really desperate need regarding the health records, then they might have access to funds beyond what was population-based to help them achieve those needs. And so I think the final recommendation was to allocate the funding to counties based on the Medicaid enrollment population as the BHO does, with directive from those local counties on which providers and in what proportion to make those payments to, with a 15% contingency withhold by the ACH to be used to address any shortfalls or shortcomings in the planning. And then if it's not used by the end of this first period, that would roll back out by the same formula. The balance would go back out based on that formula, and that they would reconvene to look at next spring's release for phase 2 funds that would come out.
So the other thing, I think, just to add to that, with the 15%, it would be there as a contingency fund, and it potentially could also be used as a consultant, to have a consultant if there was providers that needed help with readiness, because there's a really wide variety of providers, from very, very small who have very small capacity and don't have all of the things set up that would need to transmit data to 5 MCOs and to an ASO. And so that, just because I've had the experience up at North Central, I just added that on, that 15% potentially could be used for that if needed, for providers.
And we're talking about
what's going to actually come out in the letter, but that was what the conversation was about.
And could you remind us, Darlene, or Ed, again, it's the $4 million that we're talking about, the allocating.
Yes, that's correct. And there was questions about how soon that could come out to providers, in knowing that it's a very short period of time between now and January 1st, and particularly for providers that really need to get up to speed to be engaged with the full integration.
And isn't part of this also that they would be supplying the Greater Columbia with an implementation plan, so that there's some commitment on how they're going to be using this funding? Because
right. So, yeah, thank you for that. So there was a question about what becomes the triggering activity to trigger the payment or the release of funds through the portal. And the discussion had been for the organizations to conduct a self-assessment using the guidelines HCA released as a template, and be able to kind of prioritize where their investments needed to be. Probably the number one anxiety-provoking bullet point that HCA included was making sure that organizations had sufficient cash on hand to survive if the MCOs, if there was a delay in getting payment, getting that system working. And that one kind of had everybody a little bit concerned, because they were talking, initially verbally they said 4 months worth of cash on hand, which nobody has 4 months of cash on hand. And I think the bullet point was actually written to 2 to 3 months cash on hand. So that one probably took a lot more anxiety and attention than maybe it deserved. So there was an emphasis on evaluating yourself across all 13 points and seeing where your investment really needed to occur, where you knew your weakness was. And then being very quick to say if your needs exceeded the allocation, that you were alerting the ACH so it can be considered for the contingency funding. But the receipt of that reflection and plan or investment plan would be the triggering activity that would release the funds.
Yeah. But they're talking all about using the Qualis assessment around the billing and the.
I actually brought up Qualis, and I brought up how XBO had been used. I don't think there was any necessarily rubber stamp on that, but I did bring up the fact that that was how other regions had used the assessment, and it was very valuable.
Yeah,
and Triumph Treatment Services of Yakima had also echoed that they currently, and this is one of those things, they're currently contracting with XBO for consultation. And so this would represent a duplication. They've already have some funds in that consultation, and so it would prohibit them from doing something different with the dollars. But they also spoke very highly of the consultant. I think there were 4 recommendations for that consultant, right?
You know, I let you do the initial, because I was on the phone and I couldn't always hear everything, and so I don't necessarily know that.
Small clarification, the contingency fund would be administered by the ACH here.
Yeah, it would be held here because it would never release from here.
Yeah.
So there wasn't a discussion about what that mechanism would look like, so that would have to be formed. But that would be formed by the ACH, I think.
Okay.
And I think in North Central, I think the ACH actually hired XBO, because we as providers didn't had access to them, but we didn't have any funds flowing to them. So
yeah, I think it was ACH or HCA, but yeah, it wasn't a provider who hired. I know. So I know in other regions, it's either like the ASO that's hiring them if it's the county-based ASO. That may not happen in this region. So the ACH is doing it in some of the other regions too.
So it sounds like we'll be looking at this next month in June. Any further discussions around that? So now we have the community health fund discussion. Ruben?
Yes, thank you. Well, in the last budget and funds flow committee meeting, we met to decide how and recommend how to allocate the community health fund allocation so that different regions address the social determinants of health. What the discussion is about allocation. It's not about the systems or the methods of distribution. The committee kind of started a preliminary conversation about that, but that conversation needs to continue at a later time. But today's discussion is more about allocation and whether the board wants to approve the recommendation of the committee or would like us to go and do some more homework, some more analysis. So the budget for the community health fund is $997,000. Okay, the first consideration was to just go ahead and base the entire amount based on Medicaid population in the different areas, pretty much based on the main regions. The recommendation was to make it more equitable, to go back and think of other ways to make it, like I said, more equitable. So what we then recommended was that only 500,000, which is the number one right there, only 500,000 to base it solely on Medicaid population in the different regions. And I'm going to skip to number 3 right now. Number 3 is $300,000 that the GCACH would manage to address regional campaigns, provide support to the local efforts being conducted in the more local areas. And this is where we were talking about ACES before, about bringing in speakers and trainers. This is where the money would come from here. We would bring in speakers or conduct media campaigns throughout the region, supporting ACES, supporting other efforts as well. And already I've been contacting a media company, and they're about to send me a quote for some media spots, media events throughout the region. So that's the 300,000, and like I said, going back to ACES, that's where we're going to need or use some of that money to address ACES, certainly with the consultation and advice of the local regions. Hopefully, we have a good system by then. Make sure we get proper advice on it. So, and number 2, that would be $197,000 that we would allocate based on the table that's on the next page, based on the measures that the different counties, the different areas score worse than the state average. As you can see there, the red is the areas in which the individual counties are performing worse than the state average. The green is where the counties are performing better than the state average. So that 197,000 would be distributed based on the number of measures that the counties are performing worse than the state. And we presented 3 options to the committee. And if you move on back to the 3rd page, I'm repeating there the $500,000 that the committee pretty much agreed that should go on based on the Medicaid population. So the 3 options. Option 1 was to add, and that's table 1 at the bottom. Option 1 just adds up all at the bottom of the table on your left there on the other page. At the bottom of each county column, you see the number of worse than state average measures for each county. So what on table 1, what we're doing there is adding up, for example, Benton and Franklin County. You add those 2 up, they add up to 42. So then there's then you will find it in the table on the blue columns. And let me know if I'm confusing excuse me, okay? On table 1, you see abbreviated worse than state average measures. You will see that the Benjamin Franklin County, they add up to 42 worse than state measures. So that's the first option to allocate the worse than state, the $197,000. By recommendation of the committee, they asked us to look at on table 3, instead of adding up, and this is mainly having to do with multi-county liens, okay? GCACH and Yakima, they're one county, so they just left alone. So we're trying to figure out here is how to better deal with multi-county liens. So table number 3, which ended up being what the majority, 75% voted in favor of using. We had another table 2, nobody voted for that one. So table 3, what we do there is we put the multi-county liens side to side, and we get rid of the duplicate worse than state average measures. And you can see that reflected on the column in blue, worse than state measures. And that's at the far right, that's where you see pretty much what each region ends up with. And on the very far right, you will see how much would be allocated per consumer. Just to finish the page, as far as the conflict of interest that we propose, staff proposes that we go through a philanthropic institution or foundation to help distribute these funds. But again, that's a conversation for another time. And we kind of had a preliminary conversation with the committee on the 8th, I think, we met. So initially we thought of, why don't we look at all these measures, try to figure out how much it would cost to address each of them, and weight them. Okay. However, that would have become very, very time consuming, and the results would not, been guaranteed that we weighted properly. So that's why we went pretty much, not weighting them. And the goal, from my perspective, the goal of being a little bit more equitable. For example, I was hoping that any method that we come up with, Southeast Washington, the more rural areas, would have a higher amount per consumer, and pretty much both of these options do it. Table 1 does a much better job, it's more generous. Table 3, which is what the committee is recommending, it's not as generous, but either way, to me, it is table 1 is more equitable than the other. So that's any comments? Any
questions? I have one question.
Yes.
For you. So I know that when we went through the process last fall of selecting, we went through 2 rounds of eliminating projects, and one of the things that we had said is that where we had opportunity and where there was overlap, we would try to invest in and address some of the issues around oral health care needs and prenatal care. And I know those would be factors embedded in the work, and I appreciate the need for a streamlined funding mechanism. It's the same argument that the behavioral health providers have. Is there a way to, or should we, now let me back up, is this the only pot of money that would be available to address those 2 early abandoned projects, or are there other opportunities, or should we express some hope that they consider those 2 project areas in their planning? Kind of an odd or multi-part question, but
well, I'm not familiar with the process of eliminating those previous 2 projects. I don't know if Wes or Carol want to address.
So part of that is going to be addressed through practice transformation, because there are certain screenings that you can screen for in terms of pregnancy planning, oral health screenings, that if we can get the providers to provide that, regardless of whether or not we're doing the project, we feel that that is the right thing to do.
And is this a source of funds that would support or pay for those?
Actually, that's going to be the engagement dollars.
Okay.
So, the Budget and Funds Flow Committee could determine that we want to dedicate some accelerator funds towards that, if we have providers that are willing to do that, because, really, you can get reimbursed for some of those screenings anyway, right? So if we can show the providers that not only is it better health outcomes for the individual, but you can get reimbursed for it, it seems kind of like a win-win. That the community health fund is really meant to be more for the community, for the lens to determine really what are the needs in their region, and these funds then can support their projects or their activities, health fairs, and their outreach, so that they have some funding to work with that would support and that would be in concert with the project areas, that they would self-determine where those funds then would be.
So, and I was thinking, I was just going to ask a question. So I get meeting minutes of the from our staff that attend these different that are in our region. So is that going to be like kind of the what they're working on, like the Yakima Healthcare Coalition? Is that kind of their blueprint for how those funds will be spent? Some of the areas that they're working on,
right?
And some of the, it seems like each coalition is doing something a wee bit different,
right?
Yeah.
It would be self-determined, Lori, and we haven't figured out what that application is going to look like, but we want to work with the lens really, and not being so dictatorial about the way that the money is spent, but allow them to pursue those activities that are the highest value to them, whether that's in oral health or if it's in ACEs, but this gives them a funding source that they can utilize for that.
So I think that when we first made the decision to not go with maternal child health and oral health, we were thinking that possibly we could use some of the pay-for-performance dollars after we start seeing some success in the other areas to invest in that. It was a part of the conversation too, to say just because we're not focusing on it right now doesn't mean we can't allocate some of the investment dollars later, but maybe that's not an option now. We haven't really addressed any of the 4 projects that aren't being moved forward yet with, since we voted them off.
And we're supporting special projects in each of those areas. I'm sure Carol was about to talk about this. Obviously, we're supporting the training of a DHAT at the Yakima Reservation for full educational and living expenses for the 2 years of training. That has some great expectations. We're also supporting intentional pregnancy planning through Upstream USA. How we financially support them, we're not quite sure, but we've offered them office space to bring somebody down here to help support implementation of their program in the FQHCs throughout the region. So there are specific projects that we're supporting in those areas right now. At least we're leading up to the implementation of those projects right now.
So I guess just for clarification, we're not actually talking about this fund as something to, I mean, it would support the local health improvement network so far as they have collaborations, but we're really using the local health improvement networks as a way of breaking down our region to just distribute the funds back to the community. And it sounds like you'll find someone. And so you could potentially, when we get to that point, decide that as long as the project falls from A to Z categories, anywhere in your local health improvement region network, any of those communities could apply in whatever mechanism we need to for funds. This isn't necessarily, it was a little confusing at the beginning because it sounded like this is for local health improvement networks, but it really is not. We're just using the local health improvement network as a way of determining an allocation.
Yeah. Yeah.
Okay.
What
Making sure.
social determinants of health will address.
Right. And just making sure. It's a little confusing. I just want to make sure I'm clarifying that technically, whatever structure gets set up by the foundations or whomever you contract with to distribute the funds would be what community organizations look to address what we need addressed.
But I think that the local health improvement networks really need to develop a holistic plan for their particular network. And so it's not like we're going to have kind of a popcorn effect. It needs to be a coordinated implementation plan for that particular region. And as Ruben said, some of these regions are multi-county, some of them are one county, which is the reason for the variance in the funds, that, you know, the 500,000 would be going towards population. And then we had these two options of looking at for the 197,000. And the one chart looks at just counting each indicator once if there's multiple counties, and the other chart looks at rolling up the indicators. And so that was really our conversation about what's the difference between a one-county local health improvement network and a multi-county local health improvement network. Do we multi-count indicators, or do we count indicators once within each network?
So this is Rhonda.
Rhonda? Yeah, go ahead, Rhonda.
Yeah, sorry, I just have a quick question, and I hate to keep putting Darlene on the spot, but I don't know who all is on the Budget and Funds Flow Committee, but is that group do you believe that group is well represented of our full region in terms of this process, in terms of what kind of looking how, in terms of the three different options, was it, it looked fairly, the decision seemed to be pretty clear in terms of the allocation, but is that committee well represented in terms of geographic distribution?
I don't have that information, to be honest.
You mean who are the members?
The staff? Yeah, this is staff.
We have Brian from Signal Health. We have Three Rivers Family Foundation, Carrie Green. We have Shannon, who covers Southeast Washington.
I'm on it.
Megan's on it.
Carrie is.
Yeah, I don't need names. I'm just wondering geographically, or is it well represented? That's my only question.
We don't have someone from every county on it. Yeah. It would be, if you're asking if there's someone from every single county, the question really is there someone from every single land on it? I don't know the answer to that.
Is there someone from Whitman on this?
Well, Stephen Phoebus is listed on the committee, and he's from Whitman.
I don't know if he was on the call.
Yeah, he has not been attending. And then there's nobody from Kittitas.
Mm-hmm.
Well, Stephen did provide feedback.
Oh, okay. All right.
Even though he didn't attend
okay.
or call.
So what we did, because we wanted to look at different options for the distribution of the funds that were for worse than state averages, we asked Ruben to go back and put together another graph that looked at counting the indicators once. And so we didn't take a vote at the time of the meeting. We actually pushed it out to every single committee member, whether or not they were on the call, to provide a vote back. And so that's what you will see here is that 75% voted for the third option and 15% voted for the first option. And we didn't even show you the second one because it didn't have votes. And so we wanted to present both of those to the board for a final look before a decision was passed.
I have something that I'm just looking at this, and I'm just kind of looking at all the red zones, and I'm listening to you guys how you rated it basically. And when you're looking at worse than state average populations, I'm looking at the differences in the numbers. Population versus disparities on, there can be some huge margins there. And I'm not seeing that as things that's really been looked at. What I'm seeing is that the Medicaid population numbers are being looked at and not the disparities that are there. And so my question is, if you take it by margin, what are we really addressing in the disparities area other than just fielding money here and saying, okay, you guys are doing well or whatever. I don't know how you guys did this, but just in looking at this graph and seeing all that red, there's a lot of disparity there. And a lot of it has to do with women and children and minorities. That's what I'm seeing. And if minorities aren't getting what they need, we need to look at that and talk about that.
Well, I think it's up to the land to make that determination based on what they're seeing in those tables. That comes from I don't know if we can talk about that. That comes from the Robert Wood Johnson Foundation, if I'm understanding you. So I think that the LINs at the local level might be in a better position to make that determination.
And 500,000 is based solely on Medicaid population.
Right.
100,000 is based on.
But what I'm wondering is that in those populations, what are we missing? That's my question, because I'm reading here, the not proficient in English in Franklin County is 14.1%. That's a huge deficit if you look one line up, or one line over. It's like you're talking about difference and disparity and equity.
Yeah,
And those really equal to some big numbers. They're not. It may look small, but when you're dealing with that boots on the ground, there's actual people that go with them somewhere.
Right.
And what I'd like to know is that there's $500,000 and then there's 197, and it's like, to me, just in looking at it, and I'm not smart. There's a lot of people that are here on this board, but it looks like to me that's a Band-Aid sent over. Do what you can, and we'll talk about this next year. And I'm thinking people that are being represented, and I'm thinking about what their struggles are every day, and what's not going to be met for them, and what extra is going to be met for somebody else, because they get this and they go up, and these guys still stay down. And the equity is important to me.
Well, I don't think this money is going to be enough to address everything on these columns.
I understand that.
Hold on. But that population allocation, in addition to the determinant allocation, gives you the chance to tackle kind of the columns or rows that your area is most ready to tackle and address with money that you wouldn't otherwise have, because we don't have that money now.
Mm-hmm.
And I think, and that's kind of my next question is, is this year one funding? Is there future years funding that hasn't been stated? But I think that gives us an immediate influx of cash to start checking some of these off. And that's going to look different in each town, in each local health improvement network region. But the money for any of these counties isn't, any of these health improvement networks isn't enough. And at some point in the process, some people are going to get left behind while we take care of this measure, because they don't have that measure necessarily. And then the next cycle, hopefully we can get them on that measure. And the people who got help the first round are going to get left behind until we get everyone up to the same level or closer to that same level.
Yeah, every region is going to decide what areas they're going to tackle. And some of them, and then we're going to provide some additional support with a $300,000. For example, in Franklin County, they can probably select many of them, and I'm thinking bundle them with some ACE training, with an ACE training. We have one idea that I have, and I'm going to present to every region is we have a program here in the Tri-Cities, Strengthening Talent, the WSU program, that does excellent work. They've been doing this program at Ochoa Middle School. And this program brings in families with their 10 to 14-year-olds, and they've been doing amazing work. So when we encounter at a healthcare institution a family that's struggling with something, we can refer them to teaching resiliency. There are multiple other programs that different regions can use, even though they are throughout the state. But that's one way of addressing some of the measures here. We bundle them, and then we create a program that tackles them in a bundle. For example, then the English-speaking, the non-English-speaking population. Yeah, the campaigns, a lot of the messages, they're going to be in English and Spanish. And if we have a pocket of a taxable population that speaks another language, then we'll do campaigns in that language as well.
And I think, overall, I think what Sam said is these funds are so small for. I understand I'm just looking at this, and like I said, I'm not as smart as everybody else. I'm not the sharpest tool in the world, or in the shed, but the concerns are there for me. When I see the difference between 197 and 500,000, and the equity that is, I don't even know how to explain it in terms, but when there's programs, like say that there's a program in place, so I know that there's a program over here that teaches English as a second language, and I know that they're not going to receive the funding because of the fact that they can't take Medicaid dollars. But the LINs can say, okay, we got this money for these needs. Let's see if we can't help you help them. That kind of thing. And what is your main need? Advertisement that we're here. People to donate to our cause. How can that little bit of money be maximized to assist in those kinds of things at the ground level?
Ronnie, that could be part of what the LIN determines, is that is a focus, and that could be what the money is used for. And so that absolutely could be. It's just moving this money at this point in time out to the local networks to make those determinations, because to make that determination from a systems wide when we have this big of a region, it's really, really impossible. And if you look at these indicators, some of them may be actually heavier indicators than others, but at least what his Robert Wood Johnson looks at on the green and the red is just looking at some indicator, some tool that says this is worse than the state average in this particular region, that as that region, as Benton Franklin County looks at that, that's a consideration they need to take. The other area that is really high in non-English speakers is Yakima County. And those counties may also have the highest undocumented population as well, which this doesn't even reference, but what we know because we're in those communities. Right. Darlene, I did have a question, because unfortunately I wasn't at that meeting, but how was it that the committee came up with just only counting the measure once, even if it might apply to I'm going to take Southeast Washington, because that seems to me, when I look at this, the biggest differences in Southeast Washington between, oh my gosh, Madeline, I might need my glasses. 71,000 compared to 55,000. So there was quite a dramatic difference when you counted the difference in those two methodologies.
You know, it was really looking at equity. Again, they asked for three different scenarios. Ruben provided those three different scenarios, and they felt like it was most equitable to count a measure once instead of to add on when you have multiple counties. So that was just a decision of the committee. You all, as a board, can make a different decision, but that was the premise that they went.
So if you looked at those measures per the region so if you took this county map thing and took the counties off and put the limbs on,
that's what happened.
And then put the numbers that would be part of that, then you would end up with the not double counting.
Yeah, I know.
That is table number 3.
Yeah.
Yeah, but I mean, but it's not. You didn't do it on this. You only did it over there, and that's why I've been kind of going back and forth trying to see the numbers matched. And
sorry about that.
But no, it's okay. But so by doing it by doing it by the LIN instead of by the counties, you get this set of numbers.
Right.
When you do it by the counties instead of by the LIN, you get this set of numbers, and that's the difference.
Right.
And so anyway. I don't know if I don't know if it's more equitable or not. That's the part I'm trying to figure out, is how do I figure out what's equitable? Because that's what we're trying to go for, and that's
So
been
Southeast Washington, aging and long-term care, we roll out a lot of programs. And this, when I'm looking price per consumer, it looks a lot like how, it costs more money per consumer to implement a program or do anything in those rural counties because you don't get economies of scale. But you still have to support the infrastructure and the cost of that. So this, and I know which counties are involved in your land. It looks familiar. I mean, kind of how usually the metropolitan areas, your price per consumer is less. The other thing that we know about rural counties as opposed to, we can call them metropolitan areas, the west side always laughs when you call that. What we know is that they have other kinds of resources that those rural counties do not.
Right.
So to me, when I look to your far right, to your cost per consumer, it looks familiar to me. That's what I'd say on your funding formula.
And just
On
speaking
table 3.
to Ronnie's concern about like what is the impact that these dollars will have, is that each LIN is hopefully are in the process of being associated with a community health improvement plan, and that largely every community health improvement plan I know of includes Robert Wood Johnson Foundation data, and it will have, so it'll have these pieces in there, and they are likely highlights within those community health improvement plans. And so hopefully there will be a link between the LIN and the community health improvement plan and an implementation that these dollars can be used. A lot of times community health improvement plans sit on the shelf because there's no dollars to implement them. You know, this can be the spark to help starting to implement some of those local priorities that address health disparities within the community. So, and that's what LIN is priority, you know, like what can we move the needle on? What is our highest priority?
So one of the other things that you were speaking of, the media and that you're talking about. I've worked in media, and I've had my production company in New York, and there's a lot of PSAs out there that are already done. You don't have to reinvent the wheel, just saying.
You're right. I've already been in conversations with some foundations that they say, hey, just use our sponsor.
Right.
Just illustrate it.
And that's one too, is that you can always tag on the back end of a commercial company because they've already bought the airtime. And if you can bring them on board and say, hey, we need some sponsorship, or we need some help to get the word out, they would love to get on the end of that. This came from this person on their TV ad, but they run your advertisement or your PSA.
So where we're at that.
So your cost there is at zero or minimum.
Ronnie, are you recommending that more money goes out to the LIN and less money goes into the regional?
I was actually going to ask, how did the 300,000
Yeah,
number
that's all I'm considering.
Where is it coming? Why is it 300, not 200?
Maybe you could talk about that, Ruben, because that was initially what was presented to the community.
That's based pretty much on research that I did with a media company, how much it would cost to run pretty much like network campaigns throughout a region. And it's plus some speakers and some trainings. That's pretty much how I came up with the number.
I can say that this would be a good reason to reorganize the communications committee and to have the communications committee be advisor to this particular bucket, because the number sounds a little high to me. And I oversee every money that there is in marketing, advertising, and outreach for the state, for our organizations of Free Familia. And I think in this kind of work, we get a lot of mileage to what Ronnie has been saying. So we need to keep in mind that, first of all, regional advertising is much cheaper here than in other regions, that there's not even enough media slots, and they're not very reliable, so you need to consider that. You need to consider that you in this region are going to have 5 NCOs, not 3 or 4, so you can always send an email to Kat or Caitlin or Sarah. I mean, I would advocate for taking a second look at those 300 towns. That's a lot of money.
Okay.
There's a lot that is done by just driving vans to towns and setting up tables. That is not as expensive as 30 seconds in Univision, because those are very expensive. So just to keep in mind that maybe that number is a little high, and we could use the 100,000 elsewhere.
I actually disagree. I thought that was reasonable because he's talking not just media, but there's speakers and training that, you know, the cost of getting those folks in to stay for several days across our large region.
No, that's it. Yeah, but keep in mind that you always do those things through partnerships. You never do that thing by yourself. You always bring America Group and Molina and DFHA.
Right. Wayne agreeing to give money. Yep.
Well,
I wrote that he volunteered to everyone else.
that's what I mentioned, Caitlin and Cal.
He volunteered to everyone else.
Well, that is to get to go alphabetical.
Clarification, what is the purpose of the regional campaigns? Is that going to align with the work that the Lens is doing, or is that going to be an ACH type of focus?
It can be both, really. It can support the local effort, and it can also be a regional campaign that's uniform. So it really is up to what the board advises at a later point. You know, when I recommend, and then, you know.
So when I read this, I thought, okay, let's say 2 or 3 LINs have a similar project, then the ACH can help make the expense less for all of them by consolidating with some of these things and helping all 3 of those instead of each one doing the same thing 3 different times. So that's how I read it when you were talking about this, but maybe I didn't read it right.
So can I give a little context? So this whole idea of a regional campaign actually originated with Martine Valadez. And Ashley remembers. Because what we recognize is that in order to create a culture of health in our region, we need to be concentrating on just a few messages. Messages just get lost in any kind of a campaign. And so the idea that Martine and I had was we need to be providing support to our providers in terms of helping them be successful during the demonstration with consumers. So this funding that is empowering the LINs to make decisions around their own communities, really, and pushing that out into their communities is on the furthest spectrum of engagement. You can inform people, you can empower people. And so this money is meant to empower, that is going to the LINs so that they can get out into the community. A regional campaign, however, acknowledges that there are regional issues across our region. Emergency department utilization is huge. People not appearing for their appointments is huge. Patient activation is huge. You know, so the idea then is how do we collectively address some of these really big issues as a region? And so when we looked at the cost of bringing in a Dr. Anda or a Nadine Burke-Harris and strategizing how would that person then, if it's ACEs, and this would be a decision by the board, quite honestly, is the board would really need to determine what is it as a region that we really want to concentrate on that's going to help lift up the awareness of a community, whether it's mental health, whether it's childhood ACEs, whether it's chronic disease, diabetes. You know, I think that this is a conversation maybe that we can sit on and as a group, as a board, figure out what is the best use of that funding. But we didn't want it to be a small amount. We wanted it to be a significant amount that could be a year-long campaign where we could hit some messaging that would help the providers reach their goals and reaching the consumers. We did some conversation with Lily Gonzalez, and she is really an expert in terms of community outreach on diabetes. And what she said to us is that, Carol, in order to get some of our patients, our Medicaid patients, to the physician, is that they need this kind of intensive community outreach. They need health fairs. They need, you know, the kind of this local presence. And so the idea then is that as we're formulating these ideas, as we're hearing from the LINs, what are their local priorities? You know, how can we tie into that? How can we accelerate that? How can we build on it? So the decision hasn't been made yet about what that regional campaign is. We just wanted to make sure that it was enough, that it was meaningful, and it could be a very year-long campaign. Now, media might be cheaper over here, but I can tell you from my own experience that it is not cheap, you know, and for a 6 week,
and I know.
Excuse me, Jorge, I'm talking.
Okay, sorry.
For the 3-month campaign that I had for my media, it was $68,000 just in the Tri-Cities alone, right? Now that, granted, it was intensive, but if we're talking about a 9-county region, if we're talking about multiple spots, if we're talking about, you know, radio advertising or whatever this consultant gives us, then that's when we make the decision, is it too little or is it not enough? And we think that maybe $300,000 is a little generous, but at least we can scale back from that. So that was the idea.
Can I talk now?
So just from the grant world, one of the things that happens is sometimes you submit an application and you get results back that says you were approved but not funded because we've allocated our funding to everyone from this cutoff point because that's how many dollars we have. And if by chance we don't happen to spend all those monies or someone decides not to use that grant or has to rebudget, we will fund down the list. Could we just, not knowing what the media campaign, I think it's probably right where it needs to be, not knowing how much we're going to have to spend and what all we're going to fully do just yet. Couldn't we work on developing that, figuring out, make our decisions about what it is we want to do, and if there's additional funding, put it back into the other pot and distribute it according to the methodology we approve. I mean, we're spending money either way. Let's figure out how to get it out there so we can start actually getting some work done. Is my point.
Yeah.
Just for clarification, we changed the number, and I think as I hear Carol is saying exactly the way this should happen. I think it is just a little misleading when you read here because you mentioned media campaign and a media company. So it sounds like you're spending $300,000 in advertising, and of course you can spend $70,000 in one single campaign. But there's many ways to do outreach, and it's more like that grassroots kind of work that is done door to door. So I'm not advocating for changing the numbers. I'm saying that if we just said we're going to spend $300,000 in media, that doesn't sound as
I should have added more.
Grassroots approach.
We're going to pick your pocket first and then.
No, actually, you go for catering.
I like that. Yeah. Rhonda?
Yeah, thank you. You know, I have to say I didn't know where the idea came from, but for the last year and a half, all the community health centers and hospitals in Yakima County were in meetings trying to agree, and we don't do that very often, on what we were going to do to address the emergency room issue. And the only thing that we did agree on was a shared message that was going to be countywide. That would make a difference in our communities. And we had engaged the Ruckel House Center to facilitate our discussions because we needed a facilitator. But the idea of a shared message, a single message across all of our county was the one thing that we all agreed on that potentially could make a difference. And it didn't go anywhere because we didn't have any funding for it. So I really agree that is something that would be really essential, that we should try to keep in if at all possible.
Okay, so what I see is a recommendation for the board to approve the budget and funds full committee's recommendation to use option 3 for the allocation methodology. And I am assuming that you're including the other two categories, like that option.
Yes, that's correct.
Okay, does someone want to make a motion to approve?
I'll make a motion on behalf of the committee.
A second?
I'll second.
Okay, so we have a motion and a second. Is there any further discussion? All of those in favor signify by saying aye.
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 All those opposed? Any abstentions?
Yes.
Okay, so motion carries for that discussion, and we'll look forward to hearing all of this. When do you anticipate these funds to be available and what time? I don't know if that was covered.
And the next conversation with the committee is the process to disperse, to distribute these funds. And that's where we need to get into the application process. So hopefully soon.
Okay. So there will be an application and a process defined to be able. Okay. Okay, thank you. So the next is the CSA discussion, and we had a little bit of that prior.
Any questions?
Just a reminder, please remember the 31st is the cutoff deadline. Again, that's part of the process where we have to send those out for analysis and scoring and to receive the findings back from that so we can start writing our report, which is one of two essential deliverables for healthcare authority this year.
31st of which month?
You're not taking time off over Memorial Day, right? Right. Okay. So, any questions or additional information people would like for the CSA?
My only question would be, in completing the CSA, and you're encouraging everybody, whether you're asking for a contract or not, to complete the CSA if they want to be involved in the. Okay, and then if there's information that we don't have readily available on some of the demographics, what do you want us to do?
Do what you can.
Okay.
Please.
Question. The local health improvement networks are not filling out the CSA on their own, are they? Okay, because I think there's some confusion in Whitman County, because that's what was asked of me, if that was accurate, and so.
I talked to Scott yesterday.
Okay. I was like, no, I mean, I had to instruct the person on our team who covers that, local health improvement network, to say, like, no, we're filling this out already. Remember those questions I sent you? Like, that's what you're do this one, not that one.
Yeah, so previously we decided that we were not going to take in LOIs from networks, which was originally Kitty Task, and Whitman would fall in that bucket. So because of that, the CSA would not apply to it.
Okay. I just know there was that confusion coming from the follow-up on the Whitman County one.
And I've received some emails from people who have questions about particular areas of the CSA, and I've tried to respond to them. And if you have questions about specific questions, please feel free to contact me or Carol, and we'll try to respond to them as quickly as we can.
Or Sam.
Or Sam. Sorry, Sam too. So we can get you on the road to getting that done.
Thank you. I appreciate it. Provider readiness revote discussion.
So this long sheet in your packet is really just the result of what we had asked the practice transformation work group to prioritize and rank. So the lower the score, actually, the higher, the more important it is. Okay. So and these are attributes change concepts from several different resources, some of them even coming from our budget and funds flow principles, guiding principles, also some from the safety net change concept. And I worked with Wes and Sam to put together this list that we felt are really important change concepts as you're undergoing practice transformation. So out of the 17 members of the practice transformation work group, we had 15 responses. And the way that it fell out was that collaboration and leadership were on the top of the list in terms of what they felt were really important attributes. And by the way, I didn't include the definitions, but the definitions of each one of these was accompanied with this list, so that we've discussed and talked about this extensively at our practice transformation work group meeting. We went through each definition, and then they independently filled out the list and rank ordered these categories. So you can see that leadership and collaboration came out on top. Value driven and adaptive came in second, and then we had equity, transparency, and volume as third. I think it was Kevin Martin made the comment, and we talked about this a little bit earlier, how volume in some respects scored the lowest for certain individuals. And again, this was from their own, I guess, perspective. Some didn't feel that having a large volume of Medicaid clients was as important, perhaps, as having the leadership to drive practice transformation within their organizations. So we just thought we would share that with you because this will factor into the CSAs. Again, tipping my hand maybe a little bit, but we think that all of the change concepts are very important, that this is the way that the practice transformation supports them. So, anything that you want to add, Sam?
No, I'm good, thank you. I'm just excited to see the CSA come back, so.
So to tip our hand even a little bit more, that first section of the CSA with demographics has some open-ended questions. We'll just say those are very important in terms of how you answer. So just for your consideration.
And again, the CSAs are going to be scored by OHSU. So that takes the practice transformation work group out of a potential conflict of interest, and takes the staff, outside of the process as well, because we think it's important to have independence in scoring the CSAs.
Amy, do you need approval on this, or this is just discussion?
Just thought we'd show you what the practice transformation work group is up to.
So when will we get results from the CSA? Maybe I missed that.
We're going to try to have those results by the next board meeting.
Okay.
Yeah, so OHSU is on board, and we're sending them CSAs as we get them, so that they can start, scoring them right away, because it's going to take quite a bit. We probably won't have the full-blown analysis until after the June meeting, but at least we'll have the scoring and the rationale behind it, and then there's going to be a full-blown analysis that they will do for us. And since we're not meeting in July, then that will give them time to do that analysis between now and August.
So are there any public announcements or anything else that anyone would like to provide information on?
Lauren, do you still have that announcement about the grant writing workshop?
I do.
So this is just an FYI.
Let me pull it out. So Bethany Hickey with Ben Franklin Health District reached out to me yesterday and wanted to announce that there will be a grant writing class May 31st through June 1st. It's all day, both days, and there's all the information on our website. You can find it on our calendar. If you click on the event, it has all the information and a link to register as well.
It's a great skill set to have for anybody.
If you have it, they make you write them. If you have it, they make you write them.
Oh, come on.
Yeah.
It's not that bad. Kat, did you have some?
Yeah, I just had a quick comment with respect to the CSAs. At the practice transformation work group, it was expressed there's a number of assessments that are happening right now. And so I think really striving to this group for individual providers who are completing with CSAs to think of it as an opportunity to leverage and really assess their organizations across the different elements that are going to be needing to change as we move into integrated managed care, as we move into value-based payment, so that it doesn't seem like just one more path, because it is long and arduous, as Carol shared, but just that idea that it's an opportunity to really see where there are places where you can grow. Managed care organizations are really going to be interested in understanding sort of where we can support some of that work, but also sort of where that honesty lies. And we've heard from in King County, some of the providers that have already completed their current state assessments, that they actually found it, they were sort of, suspects of the process and like, oh, God, one more thing. And when they went through it, they found it incredibly helpful and actually really eye-opening for their organization as they were trying to drive towards improvement.
Sorry, one more question on the CSA. So if you have like two different programs that are different Medicaid pots, and we don't have a system that says these are duplicate, so we have health homes and we have our long-term supports and services. I'm trying to think about your Medicaid question. I'm not going to be able to say whether that's a duplicate count. Do you want both of them, or do you want just one?
Can you count unique individuals across both?
I can.
No.
My program, no, I can't.
Folks are duplicating, and you can't separate up the duplication.
I can't. Yeah.
So, probably estimate how many any of them across.
I could do that, yeah.
You probably estimate that 30% or.
Right, I could do something
Like,
like that.
I would just, and when you, if you do that, please just put a sentence about what logic you use it.
Okay.
Like if you assume 30% overlap, just say we assume 30% overlap.
And I was just going to share, they had a statewide workshop that was a collective vision for a common inventory that really brought together key stakeholders, DSA, the Department of Health, the Healthcare Authority, really looking at some tools and kind of along with that, Washington Information Network 211 has been working with the University of Washington as well as the Healthcare Authority and DOH to be able to upload the database from 211 services so that everyone can see what those social service agencies are across the state. So
that's great. That's so important.
So we're also, our Win 211 is also working with the Pathways Hub, but for those counties that won't be going through the Pathways Hub, they want to be able to have access to healthcare providers to be able to identify individuals, or resources for individuals. Some things are happening at the state level along those lines.
Great. We like the new website.
It's going through more renovations. We actually, for Win 211, and again, People for People, we help provide some administrative support for Win 211, but Win 211 actually had University of Washington students. They did it as a capstone project, so you can get them to provide pretty much just a quarter of support to be able to go in, and they took the 211 app and went out and worked with homeless individuals to really talking to the consumer about how best to be able to utilize and seek resources, that type of thing. So they'll be doing their presentation next Tuesday. Right. Cool. That'd be helpful. Right. Is there anything else? We're about 10 minutes early.
Hey, good job.
Thank
Good
you.
job.
Thank you, Carol. For your
Thank you.
class.
No problem.